Very good evening to all of you. On behalf of Relisys Medical Device Limited, I want to welcome you all in this evening and a heartfelt thanks to all the faculty and audience who have taken out their valuable time from this busy schedule. Before we commence our today's agenda, let me take you through the journey of Relisys. With the inspired vision of Dr. Abdul Kalam to make medical care affordable, the company became an independent entity under the name of Relisys Medical Device Limited in 2007. The philosophy behind the project was to design, develop, manufacture, and market high quality medical devices in cardiovascular range at most affordable prices, thus helping needy patients in India and across the globe. Backed by technocrats and medical specialists, the name Relisys emerged from the reliable system, which ensured the performance, efficacy, and safety to the patient. The strategic path adopted by the company was to use innovation and cutting edge technology besides scale of production to achieve product and pricing advantage over competition. Today, we own clean and green state-of-the-art facility built in more than 12 acres of land, 160,000 square feet build-up area, clean room of more than 60,000 square feet of 10K, HVAC building management system, built as per US FDA norms. Entire facility is certified as ISO 13485. DSR approved R&D laboratory, fully integrated end-to-end solution for manufacturing stent and catheter. And today we are one of the largest stent manufacturer in the world. This is a small glance into our facility. With the vision of expansion, in 2018, Relisys has acquired Multimedics LLP, a CE mark company, as a part of the expansion plan. We have vast product range. We have drug-eluting stent like Premier Plus, Pristine Plus, bare metal stent, Cobalt C, balloon catheter, Pearl SCNC, angiographic diagnostic catheter Anand, CE mark DAS Ensure, guide catheter Amber, guide extension catheter Access Guide, sizing catheter Squash, pulmonary artery catheter Ripacath, transcatheter heart valve, tricuspid valve as a trick valve, transcatheter aortic valve, Vienna aortic valve, expansion, which are expandable introducer sheath, Relica, which is a microcatheter. We do have peripheral vascular access product range as well, like Coral peripheral diagnostic catheter, Advert B drug-coated PTA balloon catheter, Engross PTA balloon catheter, Engross HP, this is a high pressure PTA balloon catheter, Perinity, a bare metal peripheral stent system, Peripac ACE, Sirolimus eluting peripheral stent system. Recently, we have launched abdominal aortic stent graft, which is a Metagraft AAA, thoracic stent graft system, Metagraft TAA, cutting balloon as a Pearl CV, coronary drug-coated balloon as Pearl DCB. And this is our product pipeline. Soon we are going to launch intravascular lithotripsy, central venous catheter, hemodialysis catheter, covered stent, transcatheter valve, transcatheter pulmonary valve, transcatheter mitral valve, endoventral, and of course CTO recanalization device. And today we present in more than 55 countries across the globe. With this, let me welcome you all to today's CUT COAT Chronicles, Advancing Precision in Coronary Intervention. This is a webinar series which we have launched recently, where we will witness the evidence-based discussion on the integrated CUT COAT strategy that transforming the outcome in the coronary intervention. And let me welcome you today, the facilitator of the evening, Dr. Arindam Pandey. Dr. Arindam Pandey is a senior interventional cardiologist in Manipal Hospital, EM Bypass, Kolkata. He is an experienced cardiologist with over 15 years of clinical experience. He has served a key role in renowned teaching as well as healthcare institutes. His passion for research is reflected in several published work on heart disease, device therapies, and interventional technique. Welcome, Dr. Pandey, to our program. And once again, thank you very much for your valuable time. Now I will request you, as well as I will hand over the session to you, and kindly take the session forward, sir. Thank you so much. Over to you.
Yeah, thank you so much. So basically, today we are going to discuss on the utility of cutting balloon, and we have very esteemed speakers with us. And at the same time, we
Good
have
evening.
Yeah, I think both our chairpersons have joined. Course director, Dr. Shubhanand Rai already saw. I saw him, and then Dr. Praveer Agarwal. So welcome both of you, sir. Our first speaker is going to be Dr. Vaibhav Patel, who is a senior interventional cardiologist from Pune. So without wasting much of time, let us see what Dr. Vaibhav is going to show us. Dr. Vaibhav, stage is all yours. Davinda, Dr. Vaibhav is ready, or we can see Dr. Pranav as well. So if he's not ready, we can go ahead with Dr. Pranav's presentation as well.
Yes, I think Dr. Vaibhav has already joined,
Yeah, we can
and
see him, but he's not, showing up.
yeah, so sir, yes, let us go with Dr. Pranav, and then we can come to Dr. Vaibhav.
Dr. Pranav, are you
Yes,
comfortable so that
yes,
we can
yes,
go
yes,
ahead with you? Hmm.
yes. Thank
Please
you.
go ahead. Thank you very much.
Oh, So I am here to discuss the utility of flap modification using cutting balloon in day-to-day clinical, I mean, your intervention scenarios. So though we are already using, I mean, I am audible, right?
You're perfectly audible, sir.
Hello. Yes, I'm already in the meeting. So, uh, So, so this is like a case. I mean, the patient is already there in our hospital, admitted, done just 2 days back. So we had a patient. He presented with he had a chest pain for last 4 to 5 days, and a typical anginal pain, and was hospitalized to our MICU and was diagnosed as NSTEMI. His PROPI was positive, uh, and he was having a risk factor of hypertension. Though his age mentioned on Aadhaar card is 51, but he looks around 60 years old. Ejection fraction was 50%. And basically, this was his presentation when he presented to our casualty, that is the emergency. So he had one episode of ventricular fibrillation. It was, I mean, reverted. This was his baseline ECG. The ECG was showing a left bundle branch block, and he had some LV dysynchrony and mild LV reduced ejection fraction of 50%. So we did an angio, and angiogram showed a diffuse the disease LMCA and proximal LAD. LCS also had some disease in the proximal portion. So basically, this was a epicranial view showing LMCA tight in the epicranial view, almost 70 to 80%. And proximal LAD had disease, and mid LAD again was showing a 90% lesion. Diagonal, there were two diagonals, both small vessels, and both were diseased. L6 had actually spasm, was not a critical lesion. So it looked like a 60-70% lesion. So this was his angiogram. This was the arrow caudal view, showing short left main and throughout disease. Even the proximal LAD is disease. So basically, the plan was to do a angioplasty with a strategy of putting stent from the left main ostium to uh, the middle. So started the case. So here you can see on the left side is a plain still image showing. I took a scoring balloon, so a 312, and it showed a good expansion in like the mid LED lesion and the LED segment near the proximal zone. But what happened when I took this balloon into the left main? I mean, I haven't captured the images, but there was no good expansion. I mean, those 3O was like a kind of little undersized. So the left main looked similar, not much plan. So I had another balloon with our pearl. So took a 3.25 10 pearl, and here you can see a good expansion. Okay, a good expansion both in this distal lesion and in the LMCA. Okay, so after this, this was the angiographic picture, LAO caudal view. AP canal view I have not actually saved on the CMA. So this is, though it looks tight, but the artery had opened up, and then I put up two stents, a 3 into 32 and then a 4 into 24, overlapping from the left main to the medial eddy. So this was placement of the stents. Both were well deployed, and this was the initial result after stenting. Then there was a pole dilatation distally 3.5 balloon at high pressure and with a 4.8 balloon at 14 atmospheric pressure. And this was the final result. So this was a provisional strategy. The LCX had we decided that not to touch this LCX because it was more of a spasm. So we are not having imaging at our center, but I felt angiographic result was good, and there was good. In fact, at the after plaque modification itself, there was a good gain in the lumen area. So this is another patient done last month. Patient presented as infiol MI and RCA was showing a tight lesion. So it looked like a thrombotic lesion and looks like a soft lesion on the angiographic image. But when I started the case, a 310 NC was not opening up the lesion well. So there is a lumen gain, but still it is not as per the expectation. And hence I took a cutting balloon. Took two wires to give a kind of a cutting balloon effect, but that was not so successful. So then took a pearl balloon 3.2510. Now this is a standard choice I use because it helps. The 3.25 helps to be utilized in the vessels which are almost 3.5. And this was image where it showed that there was almost complete opening of the artery. There was no, see, the advantage of cutting balloon that the dissections, if at all, they are localized and there is minimal injury beyond the segment where we are dilating. So we took a 3.528 9 V and deployed, then did a pole dilatation with 4 into 10 balloon at, across the stent, and this was the final result. So as we can see, the result is very excellent. This is both the RAO view and aleocranial view. So with these two cases, because I kept the slot for 15 minutes, so all I want to summarize the case as uh, the plaque modification with scoring balloons, angiosculpt, or with the cutting balloons is there for almost more than 15 years. But the story or the problem, what has evolved, there was always a shortage of the Wolverine balloon. Also, there was a product recall with the Wolverine balloon, and hence we were at times with limited, availability of these choices. But recently, I would say that when we are having good association with the releases in terms of we are using the product for almost last 13 years. When they had a launch of their cutting balloon, I was the first person like to take a good number of things and use in multiple cases. So I would say I have a data of more than almost 15 to 20 patients, and we have a very because this being a medical college, our usage of all the tools is very much practical, and the the threshold is very low to go for an advanced therapy. So with this, I would like to stop my presentation and
Thank you, Dr.
go.
Pranab, for showing two very excellent, elegant cases. So let me ask you one question. So nowadays, I can see more and more complex cases are actually coming for angioplasty. So in your
Yes,
institution, and what is your experience? How many percentage of patient this is only non-compliant, semi-compliant balloon, and how many percentage you need to actually use cutting balloon or
yes,
beyond that, some plaque
yes,
modification, calcium
yes,
modifications tool? What is your experience?
yes, sir. Sir, I would say that I'm the center we are running for last 10 years, And right from like the COVID test 2020, we are aggressively doing. I mean, we do imaging, we do all the kind of plaque modification. So what has happened in the last 5 years? What I have seen, those patients. So we have a data kind of when we did IVAS in patients with 40 to 50 age group and the 50 to 60 age group, we have seen that almost 50% of the plaques have a ARP of calcium that is 90 degrees, or in some patients it is 180 degrees. And on angiogram, we do not see that calcium. And especially now when we have this patient, now these cases were little young, but we have a lot of patients who are in the 60s and the 70s. So those cases, the lesion yield rate is very less with your regular NC balloon, even at high pressure. So I would say almost 20% of the cases do require a plaque modification. Either with a two wire, most of the time a double wire and a high pressure NC balloon dilatation takes care. And if it doesn't help, then 20% of the times we are needing the plaque modification with cutting balloons. We are also very liberal with sending the patient for CABG. So outrightly, those patients who are still into the higher category, where they might treat atherectomy, they're directly cleared for CABG because rotational atherectomy and all those things are very much, they're not able to offer in a rural population. So I would say that the elderly population are coming up more with ACS, and the incidence has increased as compared to whatever trend we have seen.
Thank you. So thank you very much. Wonderful cases and very good insight. So let us go ahead with the next presentation. Next presentation, I can see Dr. Shrenik Doshi. He's from Rajkot, Senior Interventional Cardiologist, Director of his hospital. So Dr. Shrenik Joshi, if you are ready, then we can go ahead with your cases.
Yeah. Good evening, everybody. And after a wonderful presentation, let us see my case. So I hope the slides are visible.
Yes, very much visible. Go ahead, please. Make it full screen. Yes.
Yeah. So I'm practicing here at Rajkot, and I'll be presenting this circumflex lesion. So my patient is a 72-year female. She's diabetic, known case of epilepsy with Parkinson's disease on treatment. She presented with postprandial angina for the last 15 days. And her echo showed hypokinesia in the circumflex territory with an EF of 45% with mild MR. So this was the angiogram. There is a tight lesion in the circ ostium here, and a tight lesion here in the mid to distal circ. This is a critical ostial circ and a mid circ lesion. The LAD had only mild disease in the mid part, and the RC also showed some mild disease in the mid segments. So this was isolated circ ostial lesion. And we all know circ ostium, isolated circ ostial critical lesions are Achilles heel to interventional cardiologists. And so what we planned here was that it was isolated circ. Let us try only drug-coated balloon and try to avoid a stent. If required, we'll put in a left main to circ stent. I was guided. So it was a heavily calcific lesion. So we upfront planned for rota assisted, and I was guided PTCA to LCX. So used a USG guided right femoral arterial puncture 7F EBU crossed with fielder FC with fine cross. The fielder went with some difficulty, but the fine cross would not cross this mid lesion. So the fielder went, but then the you can see here the fine cross would not cross this mid lesion. So we exchanged with the rota floppy wire directly from this part without the fine cross negotiating into the distal LCX. So we use the 1.5 routine burr. It's a 1.5 burr at 1.75 lakh RPM. The ostial circ lesion crossed within the first run. but the mid circ was tight. We didn't expect this to be tight. We thought that the ostium would give us trouble, but the mid lesion would not budge. Second run, it did pass. Now it went. So with 2 runs, we could cross the lesion, and we did a third polishing run at 1.4 lakh RPM. And post rota, this is what we achieved. So satisfactory passage, the opening up of the vessels we can see here with timid 3 flow now. Then we did a IVUS to understand the lesion. So this is the mid circ lesion, almost 360-degree calcium with, you can see here, cuts everywhere. So the rota has did its job. There were cuts in the circumflex. So we could achieve a 3.5 millimeter square in the distal LCX and 3.6 in the ostial LCX. And we can see here it's a large, we can see a calcium nodule here in the ostial circ. This mid lesion had a 360 calcium, this, and the ostial lesion had a this. You can see here a calcium nodule here. So next, we didn't upgrade to 1.75. We took NC balloon. First, a 2.510 NC balloon, which ruptured. Then we took a 27510 NC balloon, and we could achieve satisfactory result. This was done so that we can pass the cutting balloon easily. Post NC balloon, we took pearl cutting balloon, and this was my, I would say, first case of pearl cutting balloon. And I used to use the Wolverines previously, but was very easy and smooth in passage. So we initially took a 3x10 pearl cutting balloon and dilated both the lesions. Then took a 3.5x15 cutting balloon for the ostial circ. The mid was dilated both lesions initially with 310, then 3.5x15. Post cutting balloon, we could achieve good result. And see here, we can see there's a good result at the circ ostium and the mid lesion both. There was some spasm and some lesion here, but we didn't want to tackle this. We didn't want to stent. So next we did an IVUS to see what is happening now. So post cutting balloon, what we could achieve is a 4.6 area at the mid lesion and a 4.8 at the, this the mid distal 4.8, and the ostium we could achieve 4.5, 6.5. So the ostium of the circ had a 6.5 MLA, and the mid was around 4.6 to 4.7. This nodule was there, but still we could achieve satisfactory result. So then we decided we'll not put in a stent and decided to go ahead with a 3x30 paclitaxel drug coated balloon. So why we choose 3? Because though we dilated the ostium with 3.5 cutting balloon, but we could not achieve this area. The diameters were 3 by 2.5. So 3 was sufficient for both ostial and the mid circ. So we dilated, we applied a 330 DCB here, and this is the final result. So there was some non-flow limiting dissection here, but it was non-staining, non-flow limiting, and so we accepted this final result. Post this, we took a femoral check angio to just confirm that everything is well. The bladder is central, there is no ooze. However, a patient started having flank pain, but the abdomen was soft and there was no hematoma, no discoloration in the groin. Superficially, everything was fine. So we didn't took it much seriously. Overnight, her blood pressures remained 90 to 100 with, there was some relative tachycardia. The heart rate used to, which was baseline, 60 to 65, remained around 80 to 90. And the blood pressure was fluid responsive. She passed adequate urine. Next day morning, when we did hemoglobin, it dropped from 12.6 to 8.7. So we quickly ordered a local ultrasound. However, it did not show any hematoma or collection. But as the HB dropped, there was a borderline BP and flank pain. We went ahead with a plain CT abdomen. Plain CT showed a large retroperitoneal hematoma on the right side. This is it. You can see here, this is the collection. There was nothing superficially, but a large retroperitoneal hematoma there. However, as she was not having much of hemodynamic issue, we managed it conservatively, transfused 2 units of LRRCC, and she stabilized. On day 3, she was shifted to ward and discharged on day 4. With almost 3 months now, she is doing fine. So to conclude, we all know LCX ostium is notorious for restenosis. So cutting balloon and drug-coated balloon, so that is metal-less PCI, may reduce the risk of restenosis. And despite of all precautions and all sorts of management, complications may occur, and we should be able to first of all diagnose them and take care of them. With this, I will end my presentation, and thank you. And I would like to have comments on my presentation.
Thank you, Dr. Shenik. Wonderful case. Fantastic.
Thank you.
So very meticulously done. So I have just 2 comments. We have our expert, director as well. We go ahead with them as well. So
Sir.
just 1 comment, whether you were comfortable to do this case at radial, because nowadays you are doing 7 French radial very comfortably, number 1. And number 2, you did CT plane to find, retroperitoneal hematoma, but you cannot find the active, bleeding if you do not give contrast. So what was the reason behind doing a plain
Sir,
CT rather than going ahead with contrast CT?
Yeah. So first thing, she was like a short female, 5 feet height and 48 kg weight. So we didn't want to go from 7F radial. In case of spasms during the procedure, it is very hard to then maneuver the guide. So generally for such complex cases, better to, I prefer to do it from the groin. And with regards to why we didn't use contrast, sir, we knew there was a retroperitoneal hematoma, but she used to have borderline blood pressures. Urine output was adequate. So just wanted to confirm, and she stabilized with blood. So in case if she would not have stabilized, I would have planned a contrast CT. There was nothing which prevented it actually, but thought that better. Yesterday only I had given 150 ml contrast, and again a CT would give another contrast. So better to avoid contrast. That was the only reason. If this would not have solved the issue, if she would have remained unstable, we were planning for a contrast injury.
I can see Dr. Praveer. Sir, your comment
Yes.
regarding the case. And
Yeah, first of all, I missed, I could not comment because I was not there live, and then saw the whole case. So firstly, let me just
Can I
tell
show
about
it?
this one. This Dr. Doshi, I think it's an excellent case you've done. The only thing, you're lucky that despite going on high pressure with the cutting balloon, there was no major dissections and you could achieve good result with the drug balloon. The only thing is that supposing you have a dissection which is a major one and flow limiting, then even drug balloon does not help, and you have to change the protocol at that time to just go for a stent at that time.
Yes, sir.
It was nicely done. The only thing is that the drug balloon was slightly sized, which was much more than required. You were lucky that you did not have a dissection. When you have to go high pressure, slightly undersize that like cutting balloon. So you were lucky in your case, but and you see any kind of like balloon which is got like blades. Now so many companies are coming up, and this pearl I have also used recently is showing a very good outcomes if you are on reasonable pressures and go very gradually. In a cutting balloon, like I'm a good fan of cutting balloon. I prepare almost my 70% lesion with a cutting balloon of some kind. Right?
Okay.
So I go very gradually, 1.5, 2.5, 3. As soon as it opens, just go half up. That's all. Nothing beyond that.
Okay,
Do not be
sir.
too aggressive.
Okay.
Supposing you're opening a cutting balloon and it's not giving where it was 6 or 7 atmospheres, do not go further up first time. Deflate, go ahead, change the direction of bleeds. Then again come back to the same lesion. At times the 6 or 7 it opens up again. Second time it doesn't open, and you can slightly go higher pressures on that side. Still, you have got one scope, you can change once more blades. So that gives a predictable result with the reasonable pressures to you and without having major dissections. And cutting balloon followed by DB is a very, very good choice.
Okay. Sure, sir.
Thank you, sir. Wonderful comment. So, Dr. Shivanand Rai, would you like to make some comment about the case? Otherwise, you can, sir. Yeah.
No, the point is, I totally agree with what Praveer said. Yes, basically in the cutting balloon, using of cutting balloon, unless without going from the beginning to a very high pressure, which just acts like an X. But when you change the direction and go to the nominal pressure and go a little up, it will cut as a blade. So there is a beautiful picture in some of the literatures and how the smaller cutting balloon with a very high pressure scores the plaque, and how a normal cutting balloon of the same size and in gradual pressure does the scoring. It is a wonderful, there are wonderful pictures, and absolutely it is very important to know that how you use cutting balloons. Your success depends on this. This is number one. And number two, when you use the cutting balloon nicely, your dissection will be, nasty dissections will be less. And as you know that you can use a drug coated balloon in when there is a less than 30% of residual stenosis, as well as no dye holding dissection there, your success rate would be absolutely important, and absolutely, your success rate will be more. Number two, number two is, first of all, rota in a circumflex lesion, which is a very tortuous. I think nowadays from rota we can shift to orbital, because as you know that when you do a rota, it can make a hole. It does not change the compliance of the vessels. But when you use an orbital, it can change the this thing. Compliance of the blood vessel. And number two, if the artery is not very small, as for your case, it's a very large artery, you can use or use an orbital atherectomy, which could open the artery as well as change the compliance of the vessel, so that your balloon, cutting balloon could have been inflated at nominal pressure and made a nice this thing.
So here, like my problem was, I thought the lesion was difficult to cross at the first go. So would the orbital cross it, integrate it?
Yes, why not? If the lesion is not 90%, and in that case also, if you can open with a small balloon and just put the bar or whatever you call it to the mouth of the opening, and gradually go with the 80,000 this thing, and it can open nicely. So, and once you try it, and you will be astonished to see that how the compliance of the vessel changes. It will open at the nominal pressure, I can tell you.
Yeah, fully agree. Fully agree. So we have our last presentation from Dr. Vaibhav. If Dr. Vaibhav is ready, we can go ahead with the last presentation. Dr. Subhanand, please take over from here.
Dr. Vaibhav, I'm sharing my screen. Is that okay with you? Dr. Vaibhav, I'm sharing my screen on behalf of you, as discussed. So, Dr. Vaibhav, is my screen visible? Dr. Vaibhav? Dr. Vaibhav? So just allow us a minute.
Yes, hello.
Yes, sir. I have already shared my screen.
Hello.
Yeah, over to you. Yeah,
Yeah.
Dr. Vaibhav, over to you.
So yeah, previous speaker had done a very nice job. All two cases are fantastic. Hello, Dr. Pranav. So the topic given to me is paclitaxel drug of choice for the clinical scenario. Next. Yeah, so we know that this drug-coated balloon have revolutionized the cardiovascular intervention by providing an alternative traditional setting for our uh,
Oh.
So I think Dr. Vaibhav is experiencing some technical glitch. So and his connection is very unstable. So I would request discussion. I would request our course director sir, Dr. Praveer, Dr. Shubhan and Ray to have discussion on this the cases which we have, and then I will definitely try to resolve this technical glitch if we can. So I would request a discussion from Dr. Ray and Dr. Praveer.
Sir, I would like to have one question. Rota versus orbital. When to choose and what do you prefer?
Uh, like Dr. Doshi, rota versus orbital is a very, very good question. Only thing is that rota has been there for a long time. So all of us are more aware of rota, and it had a learning curve, which is I think now since we've been using long, the curve has come down, and we all are very comfortable with that. So changing from gear from one to other like orbital is slightly difficult for us to go into that. Though still there are some indications, niche indications for orbital are there. Supposing you want to have a really make a good room there, and the artery is not having too many bends, then I think orbital is preferred. And if you are seeing people say that if you have a some kind of like a calcium nodule, this can shave off the nodule better than rota. But as a proponent of a rota, I've been using rota for more than 20 years now. And I tell you, if you go a bigger size rota bar, you can also shave off the nodule, which we never faced the problem before this new device came in. The only painful part of this device is very, very slow. You can't be too aggressive. If you are aggressive, you will face the problems. It's too aggressive. It's too slow a device, 1 to 2 millimeters per second. When you're moving it, it's very, very slow. At times you get tired of it and you push it. Pushing is a problem. Pushing is a problem. Another advantage is supposing you are just ablating an ostium. What happens in ostium, the root of passes directly forward and there's no backward cutting. So you're bleeding in ostium. This is a good device. You can have a forward cutting also and backward cutting also.
Backward.
Cutting also. That makes sense at times. And if you're going very, very slow, it really makes a good room there. But if you are having some like major bends into the lesion, please do not go ahead with that because otherwise it's a major issue. It can be there. Otherwise, it's a good device to use. They both are, I would not say replacing each other, but they are complementing to each other in a big way. The only thing is that with time, orbital also is going to grow up.
True, sir.
Uh, if I am allowed to say a few words, what Praveer said,
Sir.
it is absolutely important. But along with it, I think if the artery is very big, you see, it's more than 3.5, and you need to finish it with a one burr, and it is not very long, as Praveer said, it is not a very long lesion, not a diffuse lesion, but his artery is very large. Probably orbital is a best tool
Yeah,
to give
yeah,
compliance, or
absolutely.
to make the
That's right. That's very,
vessel
very, yeah,
compliant.
yeah. I totally agree with that.
So, but they say with orbital, the maximum area which you gain is around 1.8.
Not
Uh,
really, but you can, this increases when you increase the speed. Like in 80,000 RPM, you will have a
Okay.
1.8. But if
Okay.
you increase this thing to 1 lakh
1.2.
20, then the size of the, yeah, this thing rotation will increase. I mean, length of, it is an elliptical rotation. So the ellipse will increase and the size increases.
Okay, sir.
yeah. Dr. Ray, if you just go back to the first presenter, like if you just see the first case, the age was only 51, right? And you saw that left main and the proximal LAD and the two diagonals, they were not small diagonals, they were large diagonals. And we
Correct.
have compromised, we have just covered the stent from left main to the LAD and a big suck coming through that. And any kind of intervention beyond that would become difficult. He's only 51. So we have to take care of these kind of things also. And giving a like a therapy for the lifelong for a person like him, I'm slightly more conservative, though I'm also very aggressive. But once I'm seeing the age of the patient, I have to give him a therapy which can lifelong last for him. And I think something should be done for that also because a lot of people right now without seeing the age and they offer a therapy in which life can be compromised later on. What do you say about it?
It is such a, such a important comment. I totally, not only I totally agree, and this is a learning experience of all the, all of us and all forums. You know, if we compare the Lima and Lima Y or whatever, all arterial grafts, and we see that it is our experience that we see that even with the drug coated balloons, drug coated stents, that curves diverge after 5 years gradually. And you cannot, whatever you do, you cannot avoid new atherosclerosis. You cannot avoid the, stent blockade, which is there for every at least 2% every year. But when you use Lima Lima Y, 20 years, there is no restenosis. So I think, whatever I think, in a patient where a Lima and arterial grafts can be given, if the patient is young enough, we should go for CABG. Or nowadays, MICAS also is coming, so CABG is not a very bad option. But PCI will be only for patients who are more than 75, 80, where the CABG is not helpful. Perhaps their PCI would be more benefited, and where everything we can do a left main, we can do anything, because there the surgery results, the initial surgeries are dismal. So it is better to go for PCI. So I think if you after Excel, after Noble, we can come to this, that uh, arterial grafts and CABG should be offered to young people, and uh, PCI should be given to elderly people. This is my thinking.
I think Dr. I totally agree with that. It has to be basically depending upon everything. We should just see that we have to just take him all through his life with the normal kind of thing, and how can we take him forward? So these things are also important. I think, is the presenter ready, or still we have some time?
I think he's ready, sir. So on behalf of him, again, I'm just sharing the
Yeah.
screen. Yeah.
Yes. Next slide.
Yeah.
So the already discussion going on drug-eluting balloon. So the clinical data from this randomized control trial of drug-eluting balloon primarily based on the studies of PCBs. So two drugs mainly we are seeing the paclitaxel and sirolimus. Next slide. Next slide. So the in vitro studies that the exposure of smooth muscle cells or endothelial cells to the paclitaxel leads to more pronounced dose depending growth inhibition compared to the sirolimus. That is what with the paclitaxel had. So these studies, what we have, the indications that BMS in ISR uh, is first three, then days in ISR. So the number you can see from 100 to almost 3 to 700. The old taxes PS was compared with the single vessel disease in the below trials. So we know that these MACE outcome and all late lumen loss had seen. Next slide. So, the preclinical study that biological differences of these three paclitaxel and sirolimus coated balloons on coronary lesions in rabbit model had shown that the PCB showed significant lesser muscle artery ratio than SCB, indicating high risk of endothelialization with the SCB than the PCB. Okay, next slide. This angiographic derived functional assessment after DCB angioplasty for de novo lesions, that is what is Picolito 6 study primarily results had shown in 270 patients that the late functional lumen loss of PCB, paclitaxel versus sirolimus at co-primary endpoints at late lumen loss had uh, uh, the PCB and these sirolimus showed similar late functional loss and late lumen loss, with NS tends towards the better functional with the uh, paclitaxel drug-eluting balloon. Next slide. So the both head-to-head were compared in some studies. So the compared with the sirolimus magic touch concept medical with a sequent neo PCB in de novo small vessel coronary artery disease, that sirolimus failed to demonstrate non-inferiority for the angiographic net lumen gain at 6 months compared to the paclitaxel. Next. So the treatment of coronary de novo lesions by the sirolimus or paclitaxel drug-coated balloon, the key points that the first in human comparison of this novel SCB with a crystalline coating to the paclitaxel, similar angiographic outcomes in the treatment of coronary de novo lesions compared to the clinically proven paclitaxel. The late lumen enlargement was more frequently observed after the paclitaxel drug-eluting balloon. Next. The this is again it's shown that the first time drug-coated balloon only PCI in a large coronary artery disease, the de novo lesions is equally as safe as effective in a small vessel disease. Next slide. This is done in almost 250 patients. The drug-coated balloon angioplasty in a larger vessels can be changed. So this is the point of discussions, that in some patients with high thrombotic burden, can we go ahead? We can discuss this topic, that the suppose it is a LCX high thrombotic burden and other vessels are normal, and it's very high thrombotic burden. The sometimes aneurysmal LCX big vessels, but it's more than 3.5 LCX, and LED and RCAs are normal. So if anybody wants to discuss, we can go ahead with the discussion. Yes, sir. So sometimes the high thrombotic burden, we can go ahead with the drug-eluting balloon rather than putting the stent at the ostial L6. That is what is the what we are going to do for these high thrombotic lesions, and we can take check shoots after 1 month. So last 2-3 months we have done almost 8 to 10 cases like this, and the stent was deferred. Only drug coating balloon was done. Next. Yes, next. This is same. This is the same that the drug coating balloon. These are indicated therapy could even more offer survival advantage in the longer term by avoiding the permanent implants like stent. Alternative of sirolimus drug-coated balloon endorsed by the many interventional cardiologists still has to be approved to the main clinical efficacy. Okay, that's what from my side. So we are done almost 8 to 10 cases in last 2-3 months. That if the lesion, pre-lesion and post-lesion pre and post-lesion, the aneurysmal dilatation is there. We are just done drug-coated balloon at the lesion site, and lesions are left alone as a bailout procedure, and stenting was not done.
Dr. Ray, any comment on that?
Sir, basically, this is a wonderful idea of leaving nothing behind. But there are two very important facts. First of all, if there is a thrombus in the artery, the proper sizing of the blood vessel is difficult, and there it is a challenge. And perhaps if you use an imaging in all cases, that would facilitate definitely. But without imaging, that would be difficult. Number one. Number two, the larger, still the evidence available from the larger vessels, it is not very sparkling as the small vessels with the drug-coated balloons. This is another point. Number three is if you look at the literature, all the microaneurysms and aneurysms that happens after drug-coated balloon happens after ACS. So I do not know whether it is very safe to use drug-coated balloons, particularly paclitaxel-eluting balloons in large vessels in acute coronary syndrome and thrombus-containing lesions. I'm not very sure.
I think that's a very, very right comment on that. Any paclitaxel, how it will behave in the long run, we are not sure about it. Because we have seen the stent with Pacli that really had it was decades back, the taxes. I think we all were not very happy with that. So now still we think that because this drug is lipid, can absorb it and it can have a long-term outcome. We have to just see. Right now we are happy with that it's giving a good result on that. But as Dr. Ray is saying that in the thrombotic lesions and in the large vessels, the role to come up, I think we have to have some experience before we can really take a call on that is the right therapy or not.
Yes. If time permits, I just want to show one case which is out of the track.
Another point I want to highlight, Dr. Agarwal would make his comments also on that. And like magic, if we consider the sirolimus as magic touch, magic touch is based on nanotechnology, but their drug release is not up to 90 days. And as we know that sirolimus is a water soluble thing and it will wash away from the tissues. Now the newer drug coated balloon platform solution which has come with some reservoirs which will gradually release sirolimus for 90 days, and they have shown a very good result. What is your comment, sir, on solution?
This is solution, like we also have it on the shelves. Uh, I think some more experience has to come in before we can decide, because the only data they have is for peripheral arteries. They don't have much data on the on the coronary arteries. So they are also looking at that, and of late I have used couple of them. So let us see. Still, is we can't be very sure that
Yeah.
what they're claiming,
Okay.
and they claim you can go for three inflations.
Mm.
First will also will have a drug, second also, and third also. How that thing is happening, I'm not sure about it.
Mm. So, Dr. Patil, you want to see this, show this case?
Hello. Yeah.
Here?
Yes, sir. I want to show this one case as.
Yeah, please.
Yeah, yeah. My voice is audible, sir.
Yeah,
Yes.
yeah.
Hello. Yes, yeah, yeah. So this is a 65-year-old gentleman had taken for a primary angioplasty, and it was first day of my one of the PG, and she had joined DM, and after 6 months she had just came to cath lab first day. As soon as what happened, I will just show this is a L6 100% and LED also having proximal 90-95% lesion. So we have taken this angio and go ahead with this PAMI. Daughtering was done and the proximal. And then I have taken the stent. We can see that as soon as I have taken this middle figure. Yeah, my voice is audible, sir.
Yeah, you're audible.
Yeah, yeah. So you can see at the middle figure, the stent's proximal end is deformed, and when it was inserting inside, it was not going inside also because of angulated Lehman and L6 angle, and it was neither coming into the guide. It was not coming from the guide was taken 6 French, and it was not coming. I have taken everything into the groin. From the groin also it was not coming out. I have taken this guide out, but it was also not coming from the 6 French sheath also. Uh, so the stent could not come into 6 French guide and sheet. So I have taken contralateral puncture, and 8 French sheet was taken on the contralateral side. And yeah, so next we have taken the 8 French sheet with the 8 French guide from the contralateral, and the wire with a stent was taken with the help of snare from the contralateral 8 French sheet. You can see that this stent, which is deformed, had captured from the contralateral side and had taken inside of the 8 French from the left side. And this bailout was done, and after that these proximal L6 was tented 2.75 into 33, and this is the final result. So sometimes this happen that the if the hardware is state was deformed because of the air uh, at the time of hello, yeah.
You see,
So
normally,
this uh, yes, sir.
when did you realize your stent got deformed?
Yeah, when I was taken inside of the Lepman, when it was going out of the catheter.
Normally, this is not the point. The stent get deformed only by two ways. One is that you are striking against the calcium, number one. And second thing,
Yes.
if the stent is not going inside, you take the guide inside and guide distorts the proximal portion of the stent. That's the majority of
Yes.
times is the reason that you go inside and coming back, the stent gets flayed up and then you can't do anything. Then it will not go inside also, it will not come back also.
Yes.
That's what happens. So we are lucky in one sense that you could take out from other groin, but when these struts open up, even pulling back at times is a problem that this can really do a like bad job for the iliac vessels, and it can really cause a nightmare to you. The best way to deal with that is supposing you've got a stent like that, and could you take out the balloon, Professor, or you could not?
It got fractured. The balloon, while taking out, it got fractured from the ipsilateral side when I was taking out.
Balloon
What
came back. No? Balloon came back, or the balloon stent was there on the balloon when you pulled
no,
it back.
so balloon was, yeah. Balloon was taken out. So balloon and stent was detached.
The balloon was out. Only the stent was
Yeah,
there.
yeah,
Right.
yeah.
So the only thing is that is you were successful in removing that part. What you can do is you can take a wire down by the side, right, and you can plaster it by the bigger stent into the iliac vessel,
Yes.
right.
Okay. Yes, sir.
But
That was one thing. If it is
no, that
detached
also
from,
that also is a problem at times because if your struts are open and you are deploying the stent to the vessel, at times it can also perforate at that time also.
yes, yes, yes.
So it's
The
it's
thing,
just a like a wild guess what you should do at that time. And
yes,
the
that was one.
another thing is that you take a 8 French sheet that you've already taken, and somehow it can be negotiated inside that you did. But with the
Yes.
snare, you did with a snare or something else?
Snare, yes, sir.
A snare,
Goose,
yeah,
goose.
yeah.
The thing was that the throughout the taking the stain from the contralateral side, the stain was on over the wire, so the wire was not out of the lumen.
Yeah,
That was the
I think
saving only.
yeah,
The
this was
thing
a
is
very
that when she had came, my one of the PG had came when she had joined this indepleter. So in that some air was there. So when she had kept, it was that tuck was there. So I come to know that it is something is wrong while attaching. So
no, it can't
that
happen.
might,
Attaching, say, supposing you push the die in and the stent gets inflated, then you're taking inside, it can happen,
yeah, yeah. So
but not with
might
the
be
air going inside.
yeah. 1 or 2 ml probably here and there had make that.
Yes.
Yeah. Yes.
Dr. Ray, what do you say about it?
Basically, I think it is that stent is distorted by the guide catheter.
Yeah, majority of
Perhaps
times.
that. And as you already said, it's always a luck to catch the stent with the snare. And
Yes,
yeah,
and no damage to the vessels.
this is really even lucky.
Yeah,
In most of the cases, during the pulling and pushing of the, deformed stent, the arteries get damaged.
yeah.
So it's a bad situation.
I think the time is nearly
Off.
finished. And if any more comments, then otherwise we can leave
Mm.
for the night.
And but Dr. Agarwal, please conclude.
Uh, I think it was all the cases were really very nice, and they always give a thought process. Whenever I'm just sitting in a meeting like that, I always learn something. So it's never a waste of time, and I think giving suggestions to juniors and colleagues is always wonderful. And Dr. Ray has been really an excellent in commenting and giving a good advice to the juniors. And I think we should keep it up and do it more often so that we keep learning from each other. Thank you. Thanks for it.
Thank you very much.
Thank you. Thanks.
Yeah, thank you. Thank you all. I will just take not more than 40 seconds. So on behalf of Relisys, I want to extend our sincere thanks and gratitude to all our faculty and audience who has joined us from their busy schedule. And I will happy to announce that, currently this program is streaming in the Cath Lab in Pan India, and we are having more than 300 online audience who has joined with us. So once again, a big thank you with all our audience and of course all our speaker, our course director, Dr. Praveer sir, Dr. Shubhanam sir. And we hope, sir, this webinar could able to bring an insightful discussion on the table. And we will continue to do this webinar series. And the next day of the program will be on 21st of February. So with this, let me conclude the session here.
Thank
So
you.
from Renaissance, once again, thank you and good night. And wish you a happy weekend. Thank you.
Thank you. Thank you. Thank you.
Thank you. Good night.
Good night.